So thank you for the mics. Could you have another microphone, wireless microphone? Yes, if you could send them to us, I would be grateful. We will be grateful. Thank you for attending this meeting. Psychedelics, therapeutic use issues and controversies. It is my pleasure to chair this session with Gabrielle FISCHER, who directs the Clinic of Addictions in Vienna, in Austria. And yeah, epidemiology and pharmacology. I will let him introduce himself. It is a very international symposium. Jeudi from Genève and Amandine LUQUIENS from Nîmes. I will give the floor to Gabrielle to introduce Eric.
Good afternoon, ladies and gentlemen. I think we are all very happy with this wonderful lunch again, and we reunite here. And I'm very pleased to share this with Joël. And as we discussed, I am happy to introduce to you the first speaker. It's Eric Strain. It's a dear colleague and outstanding researchers. I had the pleasure of knowing him for quite some time. We attended quite some international conferences on different continents together. And I'm learning here at the opening session that Eric moved into psychedelics. Eric is a professor at Johns Hopkins in Baltimore, and he has been doing and publishing pioneering work on the topic of opioid dependence. And please welcome with me Eric Strain on stage with the topic of psychedelic, the difference between hype and hope. Please, Eric.
Well, thank you. Thank you, Gabrielle, and thank you for inviting me to speak. I want to thank the organizers of the conference as well for having me here for this. Thanks, Joël, as well. So the title of my talk is Psychedelics, the Difference Between Hype and Hope. And I hope that I can convey that to you. I'm just going to keep track of my time. Convey that to you that, and I will invoke this again later, but I think we're in an era where we're seeing the pendulum on psychedelics swing dramatically from one end to the other, where they're either seen as medicines that will save the world or that they are overblown and have no efficacy. And hopefully we can find a middle ground in this area. So I am going to, for purposes today, I'm going to focus on psilocybin, in part because there's been a lot of early work with it. It continues to be used in many studies, but I realize, of course, that psychedelics is a broader term that can encompass a number of other drugs that are currently under study, most notably MDMA. 1 minute. Thank you. MDMA, which also is known as ecstasy, and has been studied extensively for the treatment of post-traumatic stress disorder. For the sake of time, I'm not going to do all the different psychedelics. I'll just use psilocybin as an example because of its use, especially as I'll come back to, in the treatment of depression. So I'm going to look at its use in the treatment of depression, and there's a lot of interest in this indication for the treatment of depression. And we can compare it to other known effective treatments. And many of the clinical trials to date, especially sponsored by a couple of the pharmaceutical companies that are involved in this topic area, have focused on depression. So for that reason, I'm going to focus in on psilocybin and depression today. So what's the hype? What's all the excitement? And what's the hope for this? And for the hype, let me say, I initially had an hour-long talk, and you'll be happy to know I cut it down. But I had a lot of slides from the popular media that were saying how great psychedelics are. And I've just taken a few of those, but you can go online and just find so many examples of this. So this is from something you may have heard of, the New York Times, and they say CEOs, chief executive officers, are tripping. Why executives are using psychedelics to get ahead. So this was from an article in the New York Times, which some people would consider sort of the newspaper of record in the United States. Here's from Nature, one of the most reputable scientific journals in the medical field. And it was an article a few years ago, hope that psychedelic drugs can erase trauma, not just ease trauma, but erase trauma. And here they were talking about MDMA or ecstasy. And then here's from another less reputable scientific journal, Rolling Stone, and they say, they had an article called The Psychedelic Miracle, How Some Doctors Are Risking Everything to Unleash the Healing Power of MDMA, ayahuasca, and other hallucinogens. So obviously it's getting a lot of attention. And then this last one was from an online article, and I had to leave it in. And this one said, and I want to highlight this. They reported the study finds the active compound in psilocybin extends lifespan of human skin and lung cells by 50% and increases survival in aged mice by 30%. Wow, right? I mean, who doesn't want better skin and to live longer? So, you know, there's been a lot of hype with these drugs. So, how did we get here? How did this get started? And while these drugs have been around for decades and decades and decades, I want to especially acknowledge this paper, which came out almost 20 years ago now. The study was done over 20 years ago. This was a paper, Psilocybin can occasion mystical type experiences having substantial and sustained personal meaning and spiritual significance. And this paper was, the first author was Roland Griffiths, who many of you may know. Roland was a colleague at Hopkins. He's the person who really led the psychedelic renaissance at Hopkins in terms of the research. He started these projects over 20 years ago. And really, Roland was what I would say is a true scientist who was willing to take on questions that others might be reticent or hesitant to take on. I want to especially note, because as I was putting these together, Roland, as you may know, passed away, and actually it was just 2 years ago last week that he passed away. He was a friend. I often tell people, I would work on Saturdays, Roland would work on Saturdays in the office, and we often spent Saturday mornings for an hour catching up, talking about either psychedelics or his trips, his vacations, my vacations, his work with caffeine, which the two of us collaborated on many years ago. So he was a good friend and colleague, and he really did do a lot of these early studies that kind of broke the ground open for others. So how did this get started? Well, essentially, this is a new psychotherapeutic class and approach. And despite 20 years of research now, there still tend to be many small studies that are open label. And I'm going to come back to this, but I think this is a real concern with the psychedelic literature, is that so many of the studies are small open label trials. And it's good to keep some sense of perspective on this, to try to get the pendulum, as I mentioned before, in the middle and to stop swinging so much and so far. So if we were talking about psychedelics 30 years ago, we would have said those are drugs that we cannot use in patients. Now they're being touted as drugs that could potentially make my skin look better, right? And me look younger, which I need. So I'm going to focus, as I said, on psilocybin for depression, as most of the larger clinical trials are for this indication. And I'm going to do three things, well, two things really. I'm going to talk about what do we know about psilocybin for depression, then I'm going to talk about what do we need to know, and then I'm going to wrap up with some final thoughts. So let's start with what do we know? And I'm actually going to talk about esketamine for a minute to kind of put this into perspective. Because I want you to think about esketamine, which is, I'm not sure if it's available actually in France, is it? Yeah, in Europe. So esketamine is available in the US. It's a treatment for depression. It's an intranasal formulation. When esketamine was being considered by the Food and Drug Administration in the USA for approval for the treatment of major depression, there were three trials in particular that were focused on. The first was in JAMA Psychiatry in 2019. 705 patients were enrolled, 297 were in the randomization phase. Popova in the American Journal of Psychiatry that same year randomized 227 patients with depression to esketamine or placebo. And then FISCHER in the International Journal of Neuropsychopharmacology the same year had a trial they published with 346 randomized patients. And if you total up those numbers in yellow, that's 870 randomized patients with major depression who were in the esketamine trials. 870. So, the Cochrane Review in 2024 looked at psychedelic-assisted therapy for treating anxiety, depression, and existential distress in people with life-threatening diseases. They published the results of that, and here's what that Cochrane Review found a year ago, published. They included randomized controlled trials of psychedelics for anxiety, depression, distress. They found 6 studies with 149 participants. And they concluded depression improved, but, quote, the certainty of evidence is low to very low. And, whoops, low to very low. So in follow-up, this year, Menon et al. Did a systematic review and meta-analysis of randomized controlled trials of psychedelic treatment for major depression. They looked at it through April of 2024, published trials. They found 6 trials with a total sample across all the trials of 427, 215 on active drug. So keep in mind, oh, and they concluded the pooled psychedelic group did better. So bigger numbers, we're getting there, but we're still nowhere near, for example, what the esketamine trials needed to move forward. So we're still in an early stage on this. So results from larger controlled trials for depression are starting to come out. And I want to give you 4 examples to highlight here what's recently come out for the treatment of depression with psilocybin. So the first example I'm going to give, or the first one, was a USONA phase 2 study published by Chuck Raison in JAMA 2 years ago. So USONA is one of the companies that is developing psilocybin for the treatment of depression, major depression. And so Chuck published this paper of a single dose of psilocybin for major depressive disorder. Now this trial, there we go, was a double-blind randomized trial. It compared 25 milligrams of psilocybin, which is probably going to be the standard dose of psilocybin, I suspect, either 25 or 30 milligrams, to 100 milligrams of niacin. 100 milligrams of niacin was a control condition, and that produces an acute psychoactive effect. And I'm going to come back about control conditions at the end of my talk. This study had 104 patients with major depressive disorder. And what they found, the USONA trial, was there was a significant reduction in the Montgomery-Åsberg Depression Rating Scale, the MADRS, for the psilocybin group, a mean change of 12.3 at day 43 of follow-up. So that's 6 weeks, right? At 6 weeks follow-up, a change of 12.3. And I'm going to come back to that 12.3 change. But let me just show you this. Here's the results that were published in JAMA. And what you see at the top is, there's the niacin group. These are the Montgomery-Åsberg change in MADRS scores. Here's the psilocybin group. This is the follow-up in days. This is day 43. And what you see here is this 12.3 difference, which is big. Keep that in mind. That's a nice, robust effect. So, a little over 100 people. Okay, example 2, Compass. So I mentioned USONA as a company. Another company is Compass that's working to develop psilocybin. Compass is interested in psilocybin for the treatment of treatment-resistant depression. They did a randomized, multi-site, 3-arm study, 25 milligrams of psilocybin, same dose as the USONA Raison study, 10 milligrams of psilocybin, which some people thought might produce a little bit of an effect, but not as robust as the 25, and then just a plain placebo, nothing, no active drug, not like niacin. And again, this was, as I said, it's treatment-resistant depression, it's a different population, and they had 233 participants, so it's almost it's twice as big as the Raison study. They again used the MADRS for their primary outcome, but they looked at it at week 3 after treatment rather than week 6, although they did look at week 12 response as well. The MADRS difference between the 25 and the 1 milligram group, I'm sorry, I think that should be 10 milligram. I think it was a 10 milligram group, was negative 6.6 at week 3, which was a significant difference. There was not generally a sustained response when they looked out to week 12. And here I'm going to show you that. So here's the results from the Compass study. This is time. There's week 12, which is how far out they go. This is the change scores in the MADRS. What you see is the blue line is the 25 milligrams. They had, I'm sorry, can I just say, the placebo condition was not placebo, it was 1 milligram of psilocybin, which is not, some people would think doesn't have an effect. So they had, the blue line is the 25 milligram, these two lines are the 10 and 1 milligram groups, and the difference at week 3 was 6.6, as I mentioned on the previous slide. So that was significant, but recall, Raison found a change of 12.3. So it's about half the effect that Raison found, and it was at week 3 versus week 6. So earlier and less of a robust effect than in the Raison study. Now, the third example I'm going to give you is another Compass study that again is targeting treatment-resistant depression. This was a randomized controlled trial of 25 milligrams of psilocybin versus placebo. Again, the primary outcome was the Montgomery-Åsberg rating scale. This was at week 6. There were 258 participants in the US. And what they found, these results have not yet been published in a peer-reviewed journal, at least as of last month. But they did do a press conference, a press release, and what they found was a significant difference in the MADRS score, a mean difference of 3.6 points. And they noted no safety issues, and none of these trials have found any significant safety issues. So keep in mind, the Raison trial from 2 years ago found a difference of 12.3. The first Compass study found a difference of 6.6. This Compass study found a difference of 3.6. Our differences are getting smaller as these trials go on, as the sample sizes get bigger, and as some of the other effects, I think, start to become less salient, and I can come back to that. Finally, the fourth example is USONA does have another study. This is still ongoing. It's a randomized multi-site controlled trial. They're doing 25 milligrams of psilocybin, 5 milligrams of psilocybin, and placebo for major depression. It'll have 240 participants in the US. There are no results yet out for this, but I think this'll be a big trial for them. And there's a lot of interest in the results from this trial. So hopefully we'll have something soon from that. So what do we know at this stage? Well, psilocybin looks promising for the treatment of major depression, including possibly treatment-resistant depression. And the effects are not as robust as one might hope, at least not in some studies. And maybe that's because some of those studies are looking at treatment-resistant depression rather than garden variety depression. And then I think another question is, are the effects sustained for a clinically meaningful time? And that's going to be really important because that'll lead to questions about whether this is a treatment that occurs once and then you're done, or if it's a treatment that you come in and do, and then 3 months or 6 months later you get a booster or something like that. So, and I'll come back to that as well. So that's pretty much what we know right now. I mean, there's lots of other studies, but there's a lot of smaller studies, open label studies, things like that. But I think what we really know right now comes down to just a small number of large controlled trials for the treatment of depression or treatment-resistant depression. So let me then turn to what do we need to know. And what do we need to know? We need to know a lot, frankly. There's a lot we have to figure out. So, and I'm gonna just talk about these 5 things and touch on each of them. I'm not gonna, hopefully I won't go into a lot of detail, but I think the first question that we need to know is, what's the best control condition? And there's a lot of discussion right now about this. There are some people who say it should just be a regular control. Some people have tried, obviously, 100 milligrams of niacin, 1 milligram of psilocybin. There's something now being touted called I think they call it the California cocktail, which is a combination of 3 different low-dose sort of psychoactive medications, like a low dose of a benzo and things like that, that people are trying. There's been some question about, should we try some oral cannabinoid to acutely produce an effect? So nobody's quite sure what's the best control condition. And there's actually a group of us meeting to try to put together a multi-center trial, which in part will be to look at different possible control conditions. The second thing we need to know is, how do we control for expectancy effects? So if you followed the MDMA study when it was being tried by Lykos, which was the company that was developing MDMA for the treatment of PTSD. Lykos did a multi-center trial, large trial, found an effect, took it to the FDA. The FDA advisory committee voted almost unanimously not to approve it for the treatment of PTSD, despite a lot of interest in it by people like veterans and other people, other advocacy groups. Lykos, and we could talk about that if people have questions about why that didn't work out. But one of the concerns that was noted was a lot of people came into that trial having expectancy effects. They were looking forward to seeing something happening. And I think that's what is happening what's happening in the field, I think, is that some of those expectancy effects are starting to diminish now as it becomes more common and there aren't the same people flying in from other parts of the country, for example, to Hopkins, to get psilocybin. You know, it's becoming more common, and it's not as sexy as something new and novel as it was, say, 5 or 10 years ago. A third question is, how much supportive treatment is needed before and after drug administration? So the way psychedelic sessions generally have operated is people come in for some number of sessions where they're just shown the room where the psychedelic will be administered. They go through questionnaires, they're acclimated to the people, or the guides who will be with them during their session. Then they come in and have a session, which typically lasts all day. And then they'll come in for repeated kind of debrief sessions over the next week, 2 weeks, 3 weeks to kind of decompress and talk through what they experienced. But nobody's really sure how much supportive treatment really is needed. We typically, in most places I think now, typically have 2 guides in the session room the day the drug is administered. One of the guides is the same sex as the person getting the medication. There's a lot of sort of wraparound psychological services that are occurring. Is that much needed? Do people really need that much? My fourth point is this cost effective? Well, let me just say, and this is where, well, before I go to cost effective, I just wanted to highlight this paper where Bob Dworkin and I, as well as Sandeep Nayak and Mike McDermott, published on psychedelics and psychotherapy as the whole greater than the sum of its parts. And for purposes of time, I'm not going to go into a lot of detail, but this gets into this question of, are the effects with psychotherapy additive, synergistic, subadditive adverse? And you can see the paper. We've got this model where we try to play out how might these effects occur when you combine a drug with psychotherapy. I'm not going to, we just don't know is the conclusion there. So then my next point is this cost effective? And if you were at the opening debate, whatever that was, Monday night, Tuesday night? Yeah. I brought this up. There's some estimates that a single psychedelic session will cost probably somewhere around $5,000 US, which is I think around 4,000 euros. Is this really effective? Well, if it works and it's sustained, yeah, it might be. If it's not sustained, then might not be. If you got to do $5,000 every 4 months, that might, add up. Maybe companies won't want, insurance companies or governments won't want to pay for that. It's also the case if the effects are sustained, then you get into this issue of, well, how does a company make money over time on this? Most of the costs are related to personnel. They're related to the guides and the pre and post dosing sessions that you have to employ for this. The cost of the medicine is not that great. So then if it works and it lasts and you only have to do it once, your margin for the pharmaceutical company is not going to sustain that, especially as people go through it and they say, okay, it worked, or they go through it and they say, well, it didn't work for me, so I'm going to go try some other medication or something else. So there's some sort of funny cost effectiveness analyses that are going to need to be run to make sure that this can work. Or alternatively, what's going to happen is we're going to have an underground economy where people are buying psilocybin and getting it used in sort of underground ways. And then the last point is, are effects sustained and for how long? And I actually this paper just came out, so I just added it. Alan Davis was a postdoc with Roland. He's now at Ohio State, was with our group as a postdoc. And this was a study that was done at Hopkins several years ago now. It's a small open label trial of the treatment of major depression with psilocybin. Again, open label, small, it was like 24, 26 people in it. But they went back and looked at 5-year outcomes for the people that were in this trial. And basically what they found was, what they found is, this is from the study, was that the effects are still working at 5 years. These are now these are Hamilton D ratings. But people, were running about 22 or 23 at baseline before they came into the study, and it's down around 7 to 8 still, 5 years out. I think they got 23 of the people they were able to follow up with. Now, most of these people also had some other form of treatment in the intervening 5 years. So it could be counseling or therapy, might have been an antidepressant. But it seems like they did have some sustained effects. Okay, so let me wrap up. Some final thoughts. So I think it's likely some of the early effect sizes were related to hype, and that promise will diminish. The robust effects that we're seeing early on in outpatient and open label studies and things like that. I don't think, though, that should decrease our hope, given that this is a new and what I would consider disruptive class of medications for the treatment of psychiatric disorders. So I'm optimistic, but I'm not wildly optimistic. I don't think it's going to put me out of a job. While it's not addressed today, these drugs may have a value across a variety of conditions, not just depression, PTSD, and other psychological distress. And I think apropos to this conference, I've been impressed with some of the results that have come out, as I mentioned the other day, for nicotine dependence. And now there's work, for example, a trial being done at Hopkins for opiate use disorder to see what kind of effects can be produced there. So I think that we'll see more and more of these results for addictive disorders. I would leave you with this. It's always good to use new medications when they first become available and their effects are still robust due to their novelty, right? So when a new antidepressant comes out, and I have a patient who's depressed, and they find out about it, it's great to put them on it right away because they have this great hope that it's going to work. And so there'll be some remission in their symptoms more often than not. But then over time, the new medication gets supplanted by something else. I think it's going to be interesting to see, for example, the GLP-1 drugs, which are now getting a lot of hype and hope for addictive disorders and other behavioral conditions. I think they could well take over some of the spotlight that the psychedelics have had over the last 20 years. So, thank you.
Thank you so much, and I think it should actually alert us to think your last sentence, let's look in the future, have some hope, but there might be new molecules. But before we discuss this, we continue with Daniele. No, we have at the end. Okay. This I have learned is the custom at this conference.
Okay, we can do that. So now I will introduce the next speaker, is from Geneva. Is the head of the service d'addictologie des hôpitaux universitaires de Genève, Daniele ZULLINO, qui est probablement un des meilleurs spécialistes, en tout cas celui qui a le plus.
Probably one of the best specialists, the one who treated the most patients with psilocybin, and this is what he's going to tell us about. Thank you, Daniele. Well, thank you for the invitation, thank you for your introduction, and thank you for your presence here today. So, I come from Switzerland, and Switzerland has a tradition. I would like to talk about this as well. We have a certain experience now in Geneva since 2020, and I'm going to talk about the conceptualization and addictology, but especially about the integration of the approaches in a psychotherapeutic context. We're going to talk about pharmacology of the substances, and this can be integrated in a psychotherapeutic context or not, but we'll see about this right after. I'll repeat once again what we will be talking about. Psychedelics. We've described a few classes of psychedelics. They're the classical ones, and we talk about LSD, psilocybin, DMT, mescaline, ayahuasca, mescaline, and currently are available for treatment in Switzerland. Those who are available, LSD, psilocybin, and mescaline. So you see, DMT is an atypical substance compared to LSD and psilocybin. I'm not going to go into details, but it was mescaline rather. DMT will be at disposal in the future years in Switzerland. Research is ongoing currently. So this is interesting also as a substance. There are certain advantages to it. I'm going to talk about LSD and psilocybin, mainly two substances we use in Geneva. Given that we have an addictology service, we decided not to use MDMA, and there are 2 and 3 reasons to this, and I'll come to that later. So what happened in Switzerland? Why have the Swiss decided to talk about it or must talk about it? Because the first substance used, LSD, the first substance really investigated also, synthesized in Bâle by Albert Hofmann in 1943, and even a few years before, but he discovered the effects of LSD by self-experiencing it. And he decided to try to ride his bicycle home after having taken some LSD. So this is the bicycle day. Albert Hofmann didn't just discover LSD, he's also the first one who has isolated psilocybin. And after his trips to Mexico, he sent the samples to Paris, and then they finally came to Albert Hofmann, and he decided to use these hallucinogenic mushrooms as well. So this is the first psychedelic phase, the therapeutic phase or research phase, but also all of the period of the first psychedelic hype in the 60s with the hippie movement, which stopped, but not because of a Swiss action, but because of this gentleman here and his friends, Richard Nixon, who decided for political reasons to put these on the list of illegal substances, and research stopped immediately at the beginning of the 1970s. Not completely, because there was a slight part of the world, not a French village, but Switzerland started again to work on it, and in research, starting at the end of the 80s, on simple topics, LSD and MDMA, but also the Federal Office of Health that authorized a certain number of doctors or physicians to practice with MDMA, the psycholytic therapy. Then in 2006, Albert Hofmann's children and a group of colleagues decided to write to the Swiss government and ask if they couldn't start this research with patients again. And the minister at the time accepted, and they did it with patients at the end of their life, and they could use it. And then the federal health government decided to exceptionally accept it, patient per patient, to use the psilocybin and LSD. And then since 2020, we are also using it in Geneva. In Geneva, since 2020, we've been treating patients, and we had last week gone over 500 patients. We have a new series of patients now 940 sessions next month, almost 1,000. Last year, 600 patients, a whole spectrum of diagnosis that are possible. This is not a prospective research. This is really a natural compass with authorizations that are exceptional. Not really off-label, because the substances are not yet authorized to be put on the market, but this is the principle. So you see that we have a psychiatrist, but also it goes beyond psychiatry. What we know well is the efficiency of psilocybin on headaches, but we have other diseases, neurodegenerative diseases, for which there's a certain interest when looking at these substances. And we can discuss about this later. Among our clients, we treat them for resistant depression or addictions with scientific data that help us have the right arguments. And of course, we have a number of patients who have a second diagnosis, or well, get that treatment after a second diagnosis. Sorry. So this is what it looks like. It's not very esoteric, but this is what we turn our glance to the inside. We look inward, and sometimes I fight not for people to add candles and stuff. We decided for this everything to be neutral, and in literature we showed that plants can add things. Otherwise, the usual method with a mask that darkens your eyes, with a headset maybe, and playing music. Patients have the choice between different positions. We can have a mattress on the floor. This is what most patients choose. And if they wish, they can have a lounge chair. Everything is possible. So what we use mainly is LSD, 100 milligrams, sometimes up to micrograms, and sometimes to 100 micrograms. So these are the standard doses. So psilocybin 25 milligrams, sometimes 30. And we'll at the first session gives an effect immediately. And we practically always succeed to have the expected or effect of this mystical feeling that is induced. And you see the difference between LSD and psilocybin. LSD lasts longer. The quickness with the products that we have at hand are similar. If we look at products that we have on the market, on the black market, psilocybin is quicker. Effects, antidepressant and anti-anxiety effects at 30 days after the first intake have an effect. They have an effect on patients outside of these prospective studies as well. But what is interesting, it also works with those who have an addictive disorder and those who don't. So addiction is not a limiting factor to the antidepressant effect and anti-anxious. Several models of therapy with psychedelics, PAT. So what we just heard about, but not fully, is that the pharmacologic effect. People think that's good with a preparation. The preparation helps to get to these psychedelic results. So there are 3 phases, and there are 3 phases: preparation. You prepare the patient who comes in. There are a few innovations on therapeutical aims, what should be experienced, how you prepare the patient for that, the follow-up, and the follow-up that comes after the integration, a discussion on the person's experience and the lessons learned, the teachings in their daily life. The third model in Switzerland that we use is a model that anchors this experience in a psychotherapeutical approach. This psychotherapeutic approach with substances, when the psychotherapy is not working anymore. There are insights that were active, maybe there were progress, but after a while, something stops. So it's not necessarily the severity of the disorder, but it's the fact that the psychotherapy doesn't move forward. And the three phases are simply integrated. The idea is to relaunch a psychotherapeutic process and to channel it. So for the moment, in this psychotherapy that wouldn't work any longer, we could wonder whether this intervention would not be interesting to begin in the beginning to accelerate things and when launching this psychotherapeutical process. So there are several models when it comes to the doses applied or the effect looked for. Today, what we use is the psycholytic therapy. So it was developed in Europe at the end of the 50s, beginning of the 60s in Switzerland also. And this was inspired by psychoanalysis, and doses were low to medium in order to be able to interact with the patient. This is what is used currently in Switzerland with MDMA, which doesn't produce the same effects or as deep effects as psilocybin and LSD do. With this psycholytic therapy, it's a psychoanalysis or an orientation under substance. So the idea is to facilitate, amongst others, the associative work. So this psychedelic therapy was developed mainly in North America during the first psychedelic period, 1 to 3 higher doses. This is what is used most of the time, and we are seeking a peak experience, a mystical experience. The therapist doesn't intervene immediately, and all the integration work is done the next day or the following weeks. Then the third model, for which we don't yet have the proper data, it's called microdosage, where we give doses that are not psychedelic as such. It's what we use, as you have seen in our studies, the current studies. So these are doses where the person doesn't feel a psychedelic effect, maybe a light effect, but currently, this is what is used to stimulate creativity. Mood data are contradictory for the moment, but interesting nevertheless. So what are the effects and that these substances have induced? This is the Zurich group that made a great job, beautiful work here, and structured things in 3 parts. What is often very looked after, this visionary restructuration. So it's visual with eyes closed, sometimes with higher doses, and everything can start moving. People can have alterations of their perception of space, a physical perception, etc., etc. So these are not hallucinations, as long as the person is still conscious of this induced effect. So these are just alterations of their perception. Not only alterations of their perception, but also an attribution of the importance, the symbolic importance we give to these perceptions. For example, a table remains a table, but it's white, and whiteness has a symbol, a signification. It has 3 feet, white and 3 feet. Everything has a signification, a meaning. And then this can be used and worked on in a psychotherapeutic way. Second part, which is maybe the most important, that of this oceanic boundlessness. Everything becomes, everything, the ego dissolves, everything, the difference between ourself and the other disappears. I am you, you are me. The world, the whole world is inside of me. I am the whole world, myself. So this psychological distinction between ourself and the rest of the world disappears. And this has a few consequences. Thank you. So my problems can be, we can balance it out and see what's real or not. So time changes, time can stop or disappear. If there's no time, there's no future. If there's no future, there's no problem. So this experience can be a trigger for a therapeutic process. The third part, less pleasant, usually, the bad trip, we call it anxious ego dissolution, AED, dissolution. So these are difficult moments with difficult emotions, and in the meantime, we saw that this is a very positive prognostic factor. For addictions, usually we can say that there are 2 great pillars, therapeutic pillars. The question, the motivational interview and the exposure. What is the motivational interview? So what is the life plan that I want to develop, or the one that I've had up to now, the one I'm living now? And exposition, how can I think differently, behave differently? Now the question that is asked is how PAP can intervene, how can it catalyze these processes? One effect that the substances have, and I'm going to cover this quickly, you saw that since you saw presentations on psychedelics, on the left side, the placebo effect, and then the circle around are regions in one's brain, different regions of the brain, and then the lines connect them. This is the synchronization between different regions of the brain, and you can see that on the left side, not everything is possible. There are some connections, some communications that are possible, and some others are not. There are neuronal police people who are responsible for this coordination or synchronization, and psilocybin reacts on this and deregulates things. So there are things that become possible, connections that become possible that are usually not. And this is what I call the carnival of neurobiological carnival, rather. Everything is possible. There are consequences in neuroplasticity, not just a neuronal reorganization, but also a long-term effect, and sometime over a few months of stabilization of these new possible connections. So the therapeutic effect can also be explained neurobiologically. What is a psychological disorder? The desert, always the same thing, always behavior, cognitive behavior, monopolized. The addiction is the answer for a search of use of a product, a substance, to find an escape. So what is recovery? Recovery is the opening up to new possibilities, new possible care, developing a new self also. So this is psychotherapy, developing alternatives of thought and behavior where there is a rigidification around a behavior. The neuronal reorganization and neuroplasticity are supposed to, at this point, to support this process. The pharmacotherapy in support to psychotherapeutical processes. In the end, a psychotherapy, but any behavioral reorganization is always done in two phases. A first phase where we create new choices, and then it's about choosing. The first phase, the carnival phase, and the second one, when you make the decision or when you converge. So the experience, the psychedelic experience, correspond to the first phase and the support of the first phase. I think I still have 10 minutes, but I'm going to move quicker. I will send this presentation that you will be able to download after. I have so many things I would like to tell you. What are the future outlooks? We have this substance that acts for hours. We see it has a cost, it takes time, and we're not yet sure that we can have the results that can be used. So eventually we need to stop because it's too long. And Mr. Lifty started thinking about it. We can stop the effect with ketanserine, but there are secondary effects. So after 2-3 hours, you can stop. The second method is DMT or mebifetine for phases type 2 that have a short effect. DMT, the effect takes, 5 minutes. So you can combine the different techniques with a deep induction of the effect, and then right after other interventions. So it's a mix of psycholytics and psychedelics. Many questions remain without answers or unsolved. The duration of the psychedelic necessary session in order to obtain these effects, we don't know. The setting, do we really need to have a more decorated setting? There are many arguments that go against because we induce a number of things. What about music? We are quite certain today that music strengthens the deepness of the experience. But what kind of music? There are different suggestions, maybe nonverbal music, unknown music, etc. So we made the experience with different patients. It works with AC/DC or Bach and others. So the personal experience of the therapist, must one have experienced it himself or herself? It's not really. So my question for the moment shouldn't be asked because it's illegal. So for up to now, we don't have a study that mentions it. But what about the what about the necessary felt effects? I'm going to quickly close. Let's not mix up the two rebirths. So one on the therapeutic level and one that is non-therapeutic. There is a whole interest outside of the development of therapeutic needs. This is not the same discussion, and mixing them up, these two discussions is extremely dangerous. Therapeutic, you base yourself on laws that correspond to the development of medication. And the other, it's as in Swiss and elsewhere, for non-therapeutic, it's a question of civic rights. It's a political question, a political debate, not scientific. Science can provide a few elements, but we can certainly go against this scientific data. And currently, this is what we're doing. So if it's prohibited, it goes against. So delivering a medicine or a product or a therapeutic method, it's science and only science. It's not by popular voting. And I'm coming to my conclusions. This is a psychotherapeutic reactivation working with psychedelics. It opens up to new possibilities on the psychological level, but neuronal level as well. It is sort of a disruption of oneself, like a carnival, just to reorganize it better. And the importance of the set and setting is perhaps an aspect that studies up to now didn't give enough importance to, but many parameters are still to define. And I'd like to thank you for your attention. And you will find my presentation on this site, and even the manual for treatment. And thank you very much.
Thank you very much, Daniel. Perfect. And now it is my pleasure to welcome Amandine LUQUIENS, coming from the south of France, from Nîmes. She's an addictologist, and she is leading adaptation service next to Nîmes, next to the sea, and she's going to tell us about psychedelic substances and alcoholism. Psilocybin, alcohol, and depression. Hello. Thank you very much for having invited me to participate in this event. I'm going to show you the results of a study that we carried out last year and that has been recently published at the Hospital University in Nîmes, where I work. I do not have any disclosures regarding this study that was financed with public funding. So I am an addictologist, and well, since we are here at ATHS, we talk about relapsing and addictions. Addictions are chronic diseases characterized by relapsing, and we have to deal with populations that are at high risk of relapsing. Our departing point was to be confronted to relapses in patients that relapse very shortly after having abstained from drinking alcohol. So I am confronted with patients who have stopped drinking, and unfortunately enough, they relapse very quickly after they are discharged. So that's what made me launch this study. So we see that the relapse after this abstinence was a very high rate, and also with high signs of depression. So this observation, actually, I'm going to simplify the paradigm, but there are certain states, addictive states of vulnerability, and this leads to addictive processes and to this likelihood of relapsing. And we have to deal with heterogeneous patients. And actually in addictology, we're putting together different patients that have common behaviors, but they come to these common behaviors for many different reasons. So these are vulnerability factors. There are, for example, early events like traumatizing events, like the childhood of the person, or the risk of sexual aggressions, or an individual vulnerability. And this is going to activate a kind of emotional and cognitive loop that is maladaptive, and this is going to lead to the behavior of intoxication. Now here you can find the complexity of all these different factors. I know that this is a difficult slide to digest, but I have to say that again, all these people are very heterogeneous and there are different factors of vulnerability. And there are very different phenotypes. So we are in a paradigm, and this is the study in which we have been working, we are in a paradigm of really worrying about these patients that are more vulnerable from an emotional point of view. And in this study, we tried to identify them. We tried to identify those signs of depression after having abstained, after their abstinence. And this allowed us to better target these patients, to better detect the patients that will be more likely to respond to psychotherapy positively. So we carried out this pilot study. It was randomized, double-blind, with 30 patients, and the main goal was acceptability and feasibility of psychotherapy assisted with psilocybin in France. Actually, the design of the study made us randomize the patients to give them a high dose of psilocybin, so versus a low dose. So there was the issue of acceptability and feasibility, and we randomized patients to get twice 25 milligrams, so it's high dose, versus a very low dose of psilocybin of 1 milligram. So these patients had been alcohol users, and they had persistent depressive symptoms. And as it was said before, in our therapeutic model, we are providing double sense therapy, because there's this cycle of support and integration, but within a rather elaborated framework of psychotherapy. This is the kind of care that we provide. It's a program to prevent relapsing, and it's quite intensive. It's at a intra-hospital level. So we wanted to explore the mechanisms of psilocybin, and we wanted to explore the opportunities that we have at a neural plan. And the secondary endpoints were the preliminary efficacy, and we also wanted to explore the action mechanisms. And we wanted to see whether we could identify profiles associated to the response, so to the maintenance of abstinence for 3 months. So, as Daniel was saying previously, we do have a very beautiful setting. It's nice, it's next to the sea, so our patients follow this program for prevention of relapsing for 4 weeks. And there's a mind-body approach, there's a cognitive remediation, physical exercise, TBC or CBT, and patients needed to have abstinence, but no longer than for 2 months for methodological reasons. We wanted to have an abstinence of at least 15 days to see whether depressive signs would be kept. And I don't know if you can hear me now. Yeah, there's this period of abstinence, and then there's this intra-hospital period with the program to prevent relapsing. And here, patients are randomized to receive these 2 different doses, 25 milligrams versus 1 milligram. And then we have the introspective experiences, and then patients are leaving hospital, and they're evaluated on the phone after 6 and 12 weeks. So I do not have results to show because we are just finalizing the analysis, but I do have some images of the brain and also neuroplasticity. So regarding our setting, well, we are at this hospital. And here's the content of our sessions. We provided sessions for those patients who were hospitalized, and those sessions took place in their bedrooms. We have very beautiful rooms for them. It's actually the patients even bring their duvet, for example. And well, these are preparation sessions. There's one preparation session. It's one session that lasts for 2 hours. And the goal here is to avoid any adverse events during the session. And that's why there are some elements of psychoeducation during the session, so that the patient can be aware of everything that's going to happen during the session. Patients are informed about the different effects that psilocybin may have on them. There could be discrete effects or very spectacular effects. We also want to avoid as much as possible any expectation bias to have solid methodological, solid results. So we wanted to tell them that the effects could be very variable, and they can vary as well between sessions. So all of this shouldn't be a surprise for them. And because we also understand that surprise can make their anxiety increase. So we really wanted to prepare them to be able to confront all these events that may happen. And we would teach them some anchoring techniques, like meditation techniques. So before awakening their sensory aspects, they had to be able to be mindful and to center and to be able to get anchored. We also want an approach of acceptation, of engagement. So we have always been very explicit about any positive intention of change. And all this is actually read out loud before taking psilocybin. So this is the approach to sort of awake this sign in the patient. We were accompanied by the psychologist during the sessions. We would actually play music that we found in Spotify. And actually our idea was to set a certain environment that is easy to set. We really wanted to repeat this approach if it shows its efficacy. And patients, of course, as in any other protocol, well, they were wearing some eye mask in order to close their eyes. And we would remind them that later on they could share their experience, but they were also invited to have an introspective experience. And the day after that, there was an integration session. And this integration session was registered, was recorded in audio. And now we have just presented the analysis of those recordings. So the first result that is important for us is that we were able to show that there's a high societal request for this kind of treatment. We were contacted by many patients in France who wanted to be included in this kind of treatment. So actually, we had 25% of the patients who were screened systematically, and many other patients were coming just to participate in this study. These patients had heard about our study via the media, and they were interested in participating in the study, even though they had no problem with alcohol. And then there were other people who were interested, and they were alcohol users or big drinkers as well. And here, well, certain patients, they dropped out during the inclusion process because they considered that being hospitalized was a major burden for them. So this is the main criteria for non-inclusion. We didn't include patients that had co-addictions other than smoking. We didn't include either people with bipolar problems. So In 8 months, we could include these 30 patients with 10 patients in the control group and 20 patients at the high doses. These patients were quite severe, actually. So for PDI, we have 14. And what's interesting as well is that we have quite a high rate of women, which is something quite unusual compared to other studies in alcohology. Here we're talking about almost 50% women. So these patients had severe alcohol use. This was an inclusion criteria, and they had a very heavy alcohol use during the last period of consumption of 4 weeks. And they had many days of use that were more than 6 units of alcohol per day. And actually, well, I showed you the average age. The average age was 50 years old. This is the expected age. But I have to say that there were some comorbidities in the psychiatric field. There were some other disorders like PTSD, and also some patients were getting antidepressants. So half the patients were getting antidepressants when they were included in the study, and we maintained them in the study. Now, regarding the feasibility results, here we have the patients who got 25 milligrams of psilocybin. They were requesting to take a second dose. Only one of them couldn't get that dose for medical reasons, so only one of them didn't get the second dose, even though he wanted to. And for the group with 1 milligram, 4 out of 10 patients thought that they had received a 1 milligram only, and they said, well, I'm going to remain in your study, but I'm going to be in the therapeutic, I want to be in the therapeutic group. And our surprise was this preliminary effectiveness results, because we have a high rate of people who abstained from drinking after 3 months for the 25 milligram group, and 11 patients only for the 1 milligram group. Actually, it's quite a good surprise, even though our sample is very small. So even for this phenotype of depression, these results are very encouraging. And we tried to describe what could be associated to the fact of being a responder in the group of the 25 milligrams. We see here that there are 11 patients that were not drinking in the last 4 weeks, and we scored their PTSD, and we saw that these patients were facing complex PTSD. And it's the patient itself that characterizes the nature of the trauma event, whereas normally it is the therapist that evaluates this kind of trauma event. For example, if you have experienced death of one of your relatives, or if you have experienced sexual abuse or so. But here, in this case, it was the patients themselves who were characterizing and qualifying the trauma event. So this includes a complex trauma. So we could include patients that were showing higher scores of PTSD, and we showed that these patients were better responders. Another interesting result is that we were authorizing those patients to be under antidepressants. There's always the idea that antidepressants may limit the effects of psilocybin. Here we have not observed any significant difference. And actually, the rates are showing exactly the opposite, because we see that there's a a higher rate of responders among those patients who were taking antidepressants. I think that I forgot to show you this slide. Now, when you compare the intensity of the scale that allows us to see the different dimensions of the psychedelic treatment, we see that there was one characteristic that was different for those patients who had no antidepressants. The patients under antidepressants showed lower rates of anxiety, which is quite interesting to discuss. Here we have a high rate of patients who were guessing that they were on the low dose, well, we need to pursue comparative studies, and well, sometimes we are proposing these blind studies, even though patients know where they are. And the idea here is, what do you think? Do you think that you're getting 25 milligrams or 1 milligram? Well, normally patients get it right, even though in this case there were 3 patients in the 1 milligram group that did not know at all. So here we are in an open trial, and there is a certain degree of uncertainty. And this is something that we need to reflect upon when we design the study. Now, to finish, I think that I have a little bit of time. Here, this is some clinical elements. I'm going to show you some qualitative analysis. This means that we have transcribed the integration sessions. So this is the session where the patient talks about their first experience of taking 25 milligrams of psilocybin. And what we want is to see the content of their discourse, to see what they say, and to compare that with the departing characteristics, their age, their departure point, their starting point. And actually, the score on the scale that measures PTSD allowed us to see what they would become in 3 months, if they would remain abstinent in 3 months or not. So the first integration sessions allows us to discriminate groups and to see who's going to respond better. So what did we do during this integration session? We allowed the patient to express freely. Sometimes patients had difficulties to talk and to express themselves. Sometimes they were very talkative. And the psychologist that was moderating the interview had a semi-structured interview, and she just needed to ensure that the 4 questions were tackled. Did you have the expectations met? Did you find any unexpected events? What was the usefulness of this experience regarding your problems with alcohol or mood problems? So these were the kind of questions that they were asked, and then we had transcribed all the discourse. I mean, we need 4 hours to just get a 1-hour discourse. But what we did was use a software that would change the text and that would cut the text into sentences. And then the software was making a classification and separate the parts of the text that were more relevant. And in the end, you can have a text and you can categorize patients out of this, because there are certain contents that are common. And with some statistical techniques, you can do that, actually. And here, you're able to get rid of any kind of prejudice that you may have regarding the sessions, regarding the scales that we're using to measure. And it's the statistics that do the job. And of course, then we are there to check that everything is working. And we recontextualize the text. We make sure that everything is well understood. So what we did as well is that we were able, once that the different classes and categories were identified in the software, there are certain variables that are associated to these parts of text, and we ran a third analysis to see the characteristics of abstinence and to regroup that, to see what were the patients that were more likely to remain abstinent after 3 months. So 80% of the text was classified into 2 classes, which means that it was high quality. It's not usual actually to have this kind of categorization of the text. And now I'm going to show you that the first class, which was not the class that took more place. It was the class on the dimensions of the psychedelic experience. We saw here that it was this oceanic feeling, the dissolutions. And this was actually what was mentioned in the text, but what really was more prevalent in the text is what I'm going to show you now. This is a very busy slide, and I'm sorry about that, but here you see that in this software we get some words, and the words are statistically associated to this class. And then we see that the first dimension of the first class of psychedelic dimensions are physical manifestations, feelings, emotions. And what we see here is that this class was elicited by patients who had not responded to the treatment, which is quite surprising. The patients that do not respond to the treatment, they spend a lot of time describing their hallucinations. Whereas when we show the second class that makes cognitive processes appear, we see here that it's rather talking about cognitive restructurization. Also, there's a dimension of engagement into change, working on the intentions, revisiting the relationship between the patient and alcohol. Well, this is actually the most prevalent part in the text of those patients that would respond at 3 months. So this is the kind of analysis that we ran. And these were the patients, I mean, it was those patients actually that actually showed the highest PTSD score at inclusion. And I'm going to show you here an example of cognitive restructurization. This is the case of a patient who was abstinent at 3 months. And actually, here he's talking to himself. He said, now, set yourself aside and think, do you really have problems? Now, is alcohol a good way to resolve your problems? This is something that must happen, but you just need to follow your path. You need to continue your path. You need to do your projects. So this is an illustration of an interior dialogue. And regarding engagement and change of intentions, there's another patient that says, but you did have the intentions. Now you need to just put it in practice and do and make this change. Now there's this other patient here. Well, 2 patients in this case. One woman who said, but I do not need alcohol to do well. I have people who love me, and I love people, so it's going to be all right. And another patient who said, well, this is it. It's not my life anymore. This patient wanted to analyze this topic. And this patient says that she saw a bottle with a label that showed do not trespass, for example. So all in all, if we take into account the contents that were associated to abstinence, it's interesting to see that regarding abstinence, we see elements of connection to their peers, to the beloved ones, emotions, sensations, pleasant images. And associated to non-abstinence, we have negative sensations. We have the re-exposition of trauma events without feeling any kind of alleviation or relief. And there's always a lot of reference made to the setting. So it's a less immersive experience. And this is something that we find, for instance, in the room after meditation practices where you're blocked and you want to suppress your emotions. And then you are interested in other things around you to make some kind of diversion. So I think that I need to conclude. This is just to say that this inner dialogue is not measured by the scale 5D ACSC. However, this inner dialogue is made of those dimensions that we have been talking about. It comes from a questionnaire that was developed in 2022, and it talks about the experience of acceptation, of avoidance. So it would be interesting to give this kind of questionnaire in a systematic manner to patients in order to measure these dimensions. And the negative content is not inadapted, it's rather the style of adaptation that matters. It's acceptation versus suppression that matters. So the practical applications are to see whether we can optimize the process, maybe trying to target patients better, those who have trauma events before, or those who have sensitiveness. It would mean as well to assess the previous state of the patient and the therapeutic relationship, to reinforce the preparation for vulnerable patients, and to prioritize certain things, to favor this inner dialogue as a therapeutic active process next to medication. Thank you. Thank you very much for your attention.
Thank you very much, Amandine. Now we have plenty of time ahead for questions. I think we will have many questions, and I invite you to start to break the ice whenever you want. Yes, I'm going to get started. We've seen several presentations, and it is the difficulty of this type of treatment. It is purely statistical analysis. The techniques you've developed are a bit difficult since as far as the journeys are different, the influence of the certain setting, the previous psychotherapy during and after. So putting all this within a statistical tool, it seems very difficult to me. And maybe the FDA doesn't like it. They like big groups, right? Large groups. And it might be difficult to have a statistical analysis similar with other components. So this is a huge question. Maybe you want to start? Yeah, if you wish to answer. Well, the question you mentioned, we need to say that we were not too daring because we do not want to be refused by the ethical committee. So we copy and paste the criteria according to the surveys of BOCKAERT, the randomized study, when we submitted this to the ethics committee. So, of course, this could be discussed in particular with the hopes from Switzerland in the bipolar disorders. We wanted to set this to implement this study. The inclusion criteria will evolve through time, but at least it was very different to do it differently for pragmatical reasons. And Joël, can we do statistic analysis? Yes, it is not a problem, but in fact, we want to phenotype patients to abandon this notion of a big disease where we put everyone together, or do we continue? Well, there are several approaches. We chose one, but others choose others. I think the answer is in other methodologies. The FDA just assessed on the basis of a pharmacotherapeutical concept, principally with standards. I think that we will need to adapt ourselves to the psychotherapeutical concept. There are experiences, there are methods to assess it, there are methods to standardize the interventions as well as for measuring what happens in a psychotherapy. There are methods to measure what happens with a patient, with a therapist, and how these interact, and how we can calculate, and how we can decide and make our decision. And there is a supplementary fact that we do not have, that's the pharmacological intervention. The agencies must adapt themselves to that. In fact, they had to do it for other issues such as varenicline, or for the nalmefene. They had to adapt the idea that abstinence is not the only possible result, and that there are other adaptations that can be done. Maybe here the skip is larger, but it will be necessary.
Thank you. Yeah, I think we're smart people. We can figure out how to do this, right? We've done studies where, by we, I mean the scientific community, have done studies where we have controlled for the psychotherapy that's being administered. I mean, NIAAA, the National Institute of Alcohol Abuse and Alcoholism, part of NIH, has developed standardized non-pharmacologic therapies for use in clinical trials with novel agents for the treatment of alcoholism. We did, you know, Gabrielle, you know about this, we did studies 25 years ago that were placebo-controlled trials for buprenorphine to show that it was effective. And they were designed with ethical review, and they were clever designs, and you know, people accepted those trials, and they were published in peer-reviewed literature. You know, we can figure this out. I think sometimes with psychedelics, we go, woo, these are different. They aren't. They're a new class. We're going to have to think new ways to do it, but we can come up with ways to do these studies. We can stratify in clinical trials, right, by expectation. We can develop measures for expectancy effects. There's a lot of opportunity here for smart people who are interested in doing rigorous research to develop new methods, new measures, and to do these trials. And then I think we'll show they work. I think what's dangerous if we say, well, we just know they work. We can intuitively tell that they work because we gave them to 6 people and they got better. That's dangerous.
Okay. So many questions there.
J'avais une question.
Yes, I've got a question regarding the MOCA at Bureau du Roi. You had patients, 28 at La MOCA. Would we have the same results with 22 patients? The MOCA score was a bit higher. but we didn't have just this. 25% of patients had this 26 MoCA score or less, and we could see whether it has an influence or not. We have to look it on larger samples. We should check it out. We had some worries. Will these patients with very low MoCA scores could have access to introspective aspects of cognitive restrictions? Well, in fact, yeah, the outcome was not this, but we should look inside larger surveys, trials. Because the lowest was at 26 and less. On the contrary, in our criteria of non-inclusion, the fact of living with one dementia, well, it is a severe condition, but we understand why from an ethical point of view. And within the design, the future user disorder or TUS, or would it be focused on gratification or on the global disorder? An individual with cannabis, crack, heroin addiction. Well, I didn't understand very well your question. You was the gratification, recompensation. Trouble de l'usage de la cocaïne inhalée plus trouble de l'usage de PHA and alcohol, would there be a central treatment or? Well, I think that this is a general question which doesn't concern only psychedelic. We are facing methodological difficulties, and it's difficult to have it for very complex patients. We want to include patients with diverse addictions. It will be complicated to say that they are better. Should we give more importance to the patient-reverted outcomes? Subjectively, from the point of view, he finds that he has improved, but in addictology, we are soft assessments or mild assessments. These are objectives of consumption or use. So when we mix several products, the methodology is much more complex. It is not always hyper-realistic objective. So complexity, in fact, and in addition, adding heterogeneity whilst we try to understand in a reverse approach. We are in an approach more of precision. I understand your reserve. They are treated with cyclomorbin, but with more heterogeneity, I want to know what I do and on what I can be of help. Our approach was a bit the contrary, try to target in a dimensional way and not about the diagnostic, but the profiles of patients where we could think that it could work. But we remained in our survey. We will start this year with the same profile of patients with people in withdrawal with depression signals. Well, they are less severe depressions. A bit fast, madam, to try to translate it at the same time. Okay.
Colleagues, an option. Wim, please.
Yeah, maybe a question for Dr. Strain. Do you really believe that we're smart enough to deal with these things? If I think about the rejection of MDMA for the treatment of PTSD, the FDA was mentioning things like the risk of addiction. Come on, this is 40 years we have MDMA as ecstasy on the recreational market, and we don't see addiction there. So we see long-term effects, and maybe placebo effects are short-lasting, but generally not very long-lasting. And so there are many of these things. You think we as a community, as a scientific community,
we're smart enough and flexible enough to be flexible in interpreting these new medications that are really quite different. We can say they're just the same, and that's what the AMA is saying. We're going to treat you like any other medication. That's the problem. They're not like any medication. We should treat them as much as all the other medications, but they're not the same in terms, for example, of blinding. It's never going to be solved completely. So we have serious mental health problems. We have medications with very few risks, and that is actually what you said. And so shouldn't we move a little bit in our fortress of the randomized control trial, double-blind, placebo-controlled? You think we're able to do that?
Well, Wim, first of all, you know, I was in the United States a week ago, and you're asking me if I think people are smart enough, you know, to make reasonable decisions. The answer to that question is no. I don't think people are smart enough to make reasonable decisions, but I don't want to become demoralized by going down that path of thinking. So my point, though, is the Lykos review, well, first of all, the Lykos review of MDMA. Lykos, is anybody here from Lykos, the company? Okay. Lykos screwed up big time because the FDA told them, this is what you need to do for this trial. They basically, before they launched it, my understanding is the FDA was very clear, do this and this and this. And they said, we know this works. We don't have to pay attention to what the FDA is saying. Halfway through the trial, Lykos brought in a different group of people who said, oh my gosh, when the FDA tells you to do something, do something. Control for expectancy. Controlling for expectancy effect, which was a criticism, is easy. You just stratify on expectancy between your conditions. And I don't see that's a big deal. Now, so I think the FDA review of Lykos, the FDA maybe should have been more flexible. Lykos should have been more attentive to what the FDA was saying to do. I think, yeah. I think there's, you know, there's give on both sides of those equations, that equation. But I also want to be careful to say, because I think we're seeing this with the GLP-1s now, frankly. The GLP-1s are a whole new class of drugs. I don't know if providers have done this. I've got patients who are depressed alcoholics, who are obese, who are going on GLP-1s. And after years of my good psychotherapy and not decreasing their alcohol use, within 90 days, they're coming in and saying, you know, I'm not drinking as much. You know, all my good work for years doesn't work, but a GLP-1 does have an effect. So I think, but you know, again, we're saying, well, GLP-1s are game changers. They're new drugs. They're totally different. I think we can study those. I think we can study psychedelics. I think that we should be moving quickly on this. I think USONA and Compass are doing a good job in responding to, I think there are more grown-ups there than there were at Lykos. And I think we'll get some answers here pretty quickly.
I agree that they could do a good job, but the blinding issue is still not resolved, even not in their studies, although they tried very well.
There are studies now where they're doing the triple cocktail,
yeah,
which is, I forget, it's a benzo, modafinil, and something else, I think, the California cocktail, which apparently produces an effect. I mean, you know, give somebody 2 milligrams of Ativan and make them a little loopy. If I've never had a psychedelic, I'm quite upfront about that. I don't plan to take a psychedelic anytime in the near future, but if my skin gets bad, I might. But you know, if you gave me, and I've never had a benzo that I can think of. So if you gave me 2 milligrams of Ativan or 25 milligrams of psilocybin, either one, I might say, I'm feeling something. I don't know what it is, I'm feeling something. So enroll people like me in these studies if you want to see an effect. I don't think it's that complicated. I'm sorry, we should keep moving.
Oui, bonjour. Quels sont
Which are the risk of undesirable effects maybe it is a ghost which is not real, but as for exclusion criteria, the first degree of mood disorders, what are they based on? Is it described on the literature? Are there associated risks? Well, we do not have too many data to see this, but all these are precautionary measures when we look at the epidemiological studies for psychosis. There are North American studies that do not indicate the augmentation of a risk. Certain data indicate, on the contrary, a risk reduction, but these studies are with selection bias. There were also recently meta-analyses confirming that psychotic risk, long-term risk, we need to recall that under psychedelic, we are on a definition stricter. We are psychotic. This is a toxic psychosis, but on the long term, there are no data, convincing data, that we are going to induce. But per precaution, we have to avoid it. For bipolar syndrome, it is the same story. Since substance has an antidepressant effect, there might be maniac drifts. We observe them in our group, and at the same time, we have treated patients with bipolar disorders who did not drift even this clear antidepressant effect. We know it, but by precaution, it's better to exclude them from there. The importance of having a practice that goes beyond prospective surveys. We generate hypotheses, and sometimes we generate them by the clinical practice. Thank you very much, John Hopkins, for your historical work and research, FISCHER for clinicians, clinical studies, and all these patients, Amandine and her team, for this first survey in France. I speak on behalf of the French Psychedelic Society. We really need responses. We receive many mails from people who told me that we cannot be included because we are not Swiss residents. And so thank you all to the three of you and your teams. A technical question, Amandine, it's very good to have the last results. I'm not sure whether it was on all the subjects or only those who got the dose at 25 milligrams. Well, we did the analyze with those who received the stronger dose, so at 25 milligrams. The contrary, we could compensate a thing that would bother the response. So that's the idea of stimulating the analysis. Thank you. Thank you very much. Amandine had a question about the abstinence or non-abstinence in the relapse. Could you assess? We could see a topo, a relapse and full stop, or is it a relapse, a massive relapse, or with some use, or can we see whether there is a modification vis-a-vis alcohol before the experience? In any case, this survey shows that it works. These are very preliminary results, and in the paper we rolled well, we showed these results. We defined this relapse after 6 months and 3 months, and but they are the different outcomes. So there was limited 3 months duration. People were calling us afterwards. They had relapsed afterwards. They needed another dose, and we wanted to evaluate this maintenance scheme. So that is what we are going to do in the upcoming survey of last year, trial of last year. So in general terms, it depends on the number of patients. Now it is too limited to get to oral consumption.
Hello, and thank you very much for the presentation. I heard what you said about differentiation, the therapeutic differentiation, and the social context. But I was wondering whether all patients you tested were naive or not, and if it was a predictive factor, if patients told us that they already tried and had found benefits, or in a festive context or to celebrate, or not as a medical context, and if it was a predictive factor for success. Yes, well, indeed. On the last 200 patients, we have collected data in order to answer. The answer is no. It's not predictive. It's neither predictive for facts that are induced, and neither predictive for the result after 30 or 60 days. So no. And what supports the assumption that, or hypothesis that experience prepares in the things in a therapeutic framework is different from festive use or to celebrate, and it's very different. So we were going to publish an article, I hope, and with data next year. And we are analyzing this, but the answer is clearly no, which is a good news. Thank you. Thank you very much. So that was a series of great presentations, and thank you as a patriot to Amandine, because it's a great French study in a prestigious review, paper. So what about addictions and addictology is not interesting for trials, because we almost have necessarily psychiatric comorbidities, disorders of anxiety with previous trauma. And we see with this treatment, and I'm coming back to the PTSD effects with the depression, isn't it a fascinating lead that would complicate the assessment, because the inclusion criteria are very broad, and maybe it would be a first part of a question and then a sub-question. What about hypotheses about the attributable share? What about the psychotherapeutic indirect part, and the other part plays a role? And another quick question: in France, were there difficulties or not with authorities for the psilocybin for the study? And a short question: you mentioned there was an overrepresentation of women in compared to what we see with alcohol, for example, and what do you attribute this to? I'm going to try to remember all three questions. Maybe I'll start with the last, because I remember it. So indeed, there's a higher rate, well, in dual pathologies, more women, when we look at patients who come with alcohol problem. This is the first reason. The second reason is that these are just assumptions, and we would like to be able to measure this in our next study. Is this approach more acceptable for women, because there's also this psychotherapeutic aspect rather than just medication? And then the last hypothesis that I discussed about recently, it's completely hypothetical, but if you know that there are many men in the room, and I was the main coordinator, a woman, so, and it's really totally hypothetical, but it's interesting to envisage that it was more acceptable to trust a woman, to entrust a woman in order to adopt or to embrace this kind of approach. So it's fully hypothetical, but I think it would be interesting to explore these aspects. Apologies, gentlemen.
Did you answer now all the 4 questions? I don't think so. You started with the last one, right? Are you happy? Because I'm just also looking at the board. It's fine for you. So is this okay that we have one more question? Is this fine for you? Yes, it's fine. Yes?
Just answer for my first question with its first response about comorbidity.
Yes, I don't remember what you talk about the transdiagnosis. It was a hypothesis that in addictology, I think you already answered with women because you said there was an overrepresentation with comorbidities. So it didn't simplify our studies. One quick question, 12 points at HDRS for depressive characterized episodes. That's high compared to a placebo dose of 1 milligram. Were there any comparisons made with antidepressants since Dr. Strain, you talked about studies on depressive episodes, and were there comparisons with the antidepressants, and what were the results?
I think I got that. And there was a paper published in the New England Journal of Medicine by Carhart Harris 2 or 3 years ago now that was a comparison of a psychedelic to, somebody get me, is it escitalopram, I want to say? And was that right? Yeah. And interestingly, there was not a significant difference on the primary outcome measure. Now, there were significant differences on secondary outcome measures, but the a priori, the upfront primary outcome didn't show a significant difference between psilocybin and escitalopram in that study.
Oui, de façon très...
In a very pragmatic way, if we think, well, thank you for giving us this hope of to resolve things, maybe it could work at a higher scale, a larger scale. So would it be not too complex in terms of costs, because it's already been we've already talked about it. It hasn't generated any money for the pharmaceutical industry because it's not very costly. It would be successful because today we are confronted to a number of people who have difficulties in taking a life treatment. They can take it at timely moments or at certain moments, but wouldn't there be economic reasons to show the efficiency of this kind of therapy to go against all the difficulties we will meet?
I think that this is a perfect question for quick answers of all of you three. What's your guess?
It depends what we compare it to. If we compare it to a treatment, a usual treatment in which there are a number of sessions and psychotherapy in the broad sense, the calculation is done quickly. Yes, it's not very costly, but the 12 hours of or 8 to 10 years of psilocybin can be calculated very quickly. You can do the math. For us, we've done the math, and since we're not making any money with it, I can tell you that these patients come. That's already one thing, and they move forward with their projects. And then on the economic level, we've had discussions with the health insurance, and they'd like to fund it. So I think that this is a sign that it would be interesting for funders.
So we have the answer now from Switzerland, non-EU, non-American. Maybe, what do you think, Eric? It's going to be refundable for the United States if we don't have this rocket science double-blind, double-dummy studies. We have different ones.
Well, I think if we show, if it can be shown that there's efficacy, and I agree with Vim's point earlier, these appear relatively safe under the right circumstances. I think that what then becomes incumbent upon us is to develop models of treatment that are lower cost than $5,000 for a single episode. And again, I think we can figure that out. I think we can figure that out.
And finally, from European Union friends, do we need this beautiful clinic you were showing us, or do you think is there another feasibility of cost efficacy to administer the treatment?
Effectivement, je pense que...
Indeed, I think that our concern is to offer models that we can disseminate and that are not too costly, that don't require any expertise or exceptional skills, competencies that we can disseminate in public services, competencies that can help us have fair access for patients. And I join what was said. There's a sort of a condensation of time, and we talk about medico-social aspects, but the societal aspect is very important. If we prove that there was efficiency and less relapse, it would be, of course, important to have studies that are medico-economic and that prove these benefits.
So there is hope. And I look at Jean-Pierre for a program in 2 years from now. It seems to be of major interest for the audience. So would be great. Thank you very much for your participation, for asking the question, most of all for our speakers. And maybe in 2 years we get an update, and even maybe to GLP-1 and glucagon agonists in relation to our diseases. Thank you very much.